Hi everyone, this is chapter 42 of Wilkins. We are going to be talking about the acute periodontal conditions, which hopefully is all a review for you. Learning objectives in front of everything, we're going to be able to distinguish and rule out one complication from another. So let's talk about the necrotizing periodontal diseases. As you know, you've got necrotizing ulcerative gingivitis as well as necrotizing ulcerative periodontitis. Now you have to have one before you can get the other. They are all part of the necrotizing diseases. The NUG as well as the periodontitis is just as gingivitis and periodontitis is. One has attachment loss and one doesn't. So with gingivitis, there is no apical migration of the junctional epithelium. You could have blunted papillas, which is one of the hallmark signs, but it's still the attachment apparatus is intact. And that is a very fuzzy picture, but everything looks nice and swollen and yucky. Necrotizing ulcerative gingivitis, all right? It's got very classic symptoms, right? What are the risk factors for NUG? It's just what you would expect. You've got stress, you have poor oral hygiene, you have poor diet, you've got a lot of other factors going on, and susceptibility to the particular microorganisms that are in the mouth, and the spirochetes especially tend to take over, right? So there is some systemic issues going on where the mouth can't fight off the bacteria. And as you know, this is a spirochete driven situation as well, but it only takes advantage of the gingival unit itself. There's no bone loss. So the book has this down as a NUP, necrotizing ulcerative periodontitis. There does look like there might be some attachment loss. There's open embrasure spaces, which means that there's some blunted papilla going on. But this is also another picture of NUP. You can just imagine what that tissue would do if you blow air on that. It would be very, very friable, and it would be flapping, coming away from the tooth surfaces itself. What you want to do is rule out certain things, as in herpetic gingivostomatitis. Now, this is, you can see the lesions, the vesicles on the mucosa here, but look at the gingiva as well. It's very similar to what the NUG would look like. Clinical recognition, you want to be able to determine or show the signs of what is potentially going to be a problem. Sometimes with the NUG patient, you don't get them into the office until there's the pain, to the point where they can't take care of their mouth, they're waking up with blood on the pillow. So things have progressed to a certain point. But we do see patients in private practice that will come in and they are approaching NUG. So we have it NUG-like symptoms, knowing that if it went on, it would probably progress into something more advanced. So remember what the cardinal signs are for your NUG. You have the swelling, the pseudomembrane, the odor, sometimes the fever and lymphadenopathy, sometimes pain, the punched out papilla. All right, so review those, all right, because you have to have the NUG before you can get into NUP. These days, the NUG patient is going to be our college student or somebody that is on the younger side that is just going through very hard times, both nutritionally, stress-wise, and oral hygiene-wise. The NUP patient that we see oftentimes has HIV infection, as well as candidiasis and some other symptoms going on. So the hygiene care for this is to try and condition the tissue as much as we can. Initially, when the patient comes in, the tissue is going to be so sensitive that we can't touch them. So we have to get them on the chlorhexidine mouth rinse or some sort of a mouth rinse to try and control the bacteria. They need to be using a tongue swab or a tooth swab of some kind, like the little pink sponges or the green sponges that are on a stick, the toothettes, to just gently debride the area. And then we can start going in and actually scaling. Some patients will tolerate a deplaquing. We'd love to get the ultrasonic on there just to buzz out all of that bacteria, but think about what we're doing with the aerosols too. And this is one of those cases where if you're going to use an ultrasonic, you have to have a high-speed evacuation. So whether that's the first phase or the second phase, they're still in that acute phase area. Oftentimes the second appointment is when we can start doing scaling. A lot of the NUG patients don't have a lot of calculus. It's more soft debris, so to speak. So you've got to try and just get that bacteria to turn around. And unfortunately, the ultrasonic is one of the best devices for that, but it's usually a couple of appointments. And these are also the patients that you want to bring back for reevaluation and to continually motivate that patient and make sure that they are on the right track. Now, typically for the NUG, they're the patients on holiday break, semester break or something, because they just experienced final exams, or they're dental hygiene students that are trying to survive the COVID-19 virus outbreak. So trying to get them back sometimes can be problematic. So the herpetic gingivostomatitis oftentimes develops in younger children versus the older teenager that we would see the NUG in, but it's whenever that patient or that person is exposed to that virus. And this is something that is highly transmittable. The herpes virus, which is one reason why we do not see anybody with a herpetic lesion anywhere, because we don't want to spread it. We can spread it within that same person. We can spread it from one person to the next. It gets aerosolized and it can end up in the patient's eyes, in your eyes, in their nose, and you just don't want to be spreading this. So the herpes virus, once you get it, you always have it, and then it stays in the ganglia, and it just sits and waits, and it's very opportunistic. It waits until you're under stress, you're not eating right, you have an injury, or you go out in the sun for the first time. So after the first herpetic gingivostomatitis outbreak, oftentimes the patient will say they only get 1 or 2 fever blisters a year. And at that point, depending on how often they get it or the outbreak, will determine whether or not they need to be on a prophylactic daily regime of acyclovir or another medication to try and break that cycle. But once you've got that virus, you always have it. So this is something on the lips. Now, periodontal abscess is an abscess that is deeper in a periodontal pocket. You oftentimes can see the swelling. It needs to be ruled out from an endodontic situation, root canal situation, or is it a periodontal abscess? Sometimes it can be a combined. So it requires oftentimes taking a radiograph, taking probe readings of the area, and trying to debride if it's a periodontal abscess. There's something there, residual calculus, something that's causing that abscess. So that requires a cleaning out of that pocket. We don't know which one it is without a radiograph. And sometimes if there's a fistulated area, you need to be placing something like a gutta percha point in there to see where the sinus tract is, where the opening tract is. So is it a periodontal abscess or an endodontic abscess? We as dental hygienists can treat periodontal abscesses. Endodontic abscesses need to have the root canal therapy or some other therapy. So that's with the deeper pockets. A gingival abscess is more at the coronal area of the sulcus, and that is usually something stuck in the gums. Okay, popcorn hole. I've seen shellfish. Even a piece of hair can get embedded into the sulcus and create an abscess, right? But look at the difference. It's up at the gingival margin versus down into a pocket area. So that's one of the differentiations of a gingival abscess. You're not going to find the pocketing here that you would with the periodontal abscess. Then you've got your pericoronal abscess or your pericarditis. ITIS is inflammation of. This is typically around an erupting tooth, and it's most common around an erupting mandibular third molar. So bacteria gets trapped underneath that operculum, or the tissue flap, or food debris gets trapped under there, and everything swells up, and the patient then can't even sometimes bite down adequately because of the swelling. So what's the treatment for pericoronitis? Well, if the tooth needs to be extracted, that will take care of it. Or sometimes you can go in and the doctor can make a flap, use an electrosurge or a laser to debride and remove that operculum so it doesn't come back. But usually there's a deep pocket. So you're going to be seeing abscesses when it comes to your clinical practice, and we've had this in a number of chapters, so hopefully you'll be able to identify and use some critical thinking to make your best guess as far as what type of abscess you think it is, or what type of pain, because of what the patient's presenting with. So you want to have your dental hygiene diagnosis. This is what the patient presents with. This is what it looks like. So that's your dental hygiene diagnosis. It appears to be, okay, as evidenced by that type of thing. And then the dentist will make the final diagnosis. So once you find out what the situation is, you can then treatment plan and treat accordingly. And all of this does require patient education for management. How are they going to take care of situations at home so they don't recur? Post-op instructions, whatever they are, be it warm water, warm salt water rinses, irrigation, or whatever, and more frequent re-cares to be able to monitor that patient. So we want to teach our patients as much as we can about what's going on in their mouth, why it happened, and what they can do to prevent it from happening again. So again, that's everything that we can teach the patient. And of course, we're documenting what we're teaching the patient as well. And that's the end of the short, sweet, and simple chapter on acute periodontal conditions.